Good morning, everyone. Thank you for joining us this morning. My name is Camilo González Velázquez. I am an associate professor in endocrinology at the Universidad Autónoma de Nuevo León in Monterrey, Mexico, and co-host of this TIRO by MD's webinar series. Today, I am honored to present a wonderful speaker. Dr. Antonio Matrone graduated with honors from medical school in the University of Naples in Italy, to later pursue a career in endocrinology with a particular focus in thyroid oncology, studying under Dr. Rosella Elise, who we recently had the honor to host in this webinar series. And later, Dr. Matrone completed his PhD in clinical and translational sciences in the University of Pisa, and is currently a postdoctoral researcher in the Unit of Development of Clinical and Translational Sciences at this same university. Dr. Matrone has authored more than 50 research articles in well-renowned peer-reviewed journals, and today he will be presenting to us a lecture about obesity as a risk factor for thyroid cancer. So without any further ado, Dr. Matrone, the mic is all yours.
Thank you, Camilo, and thank you to all of you for inviting me for this very interesting presentation. And okay, and these are my disclosures. And this is my agenda. And we will talk about the reason why obesity and thyroid cancer could be associated, and if obesity has a role in the increasing incidence of thyroid cancer, and if this role can be important also to confer a higher aggressiveness of the disease. And moreover, we discuss some insights in the mechanisms underlying this potential association. So as you can see in this graph, we have an increase in the prevalence of obesity, but also of overweight, of the association of overweight and obesity between 1975 and 2015. And as we can see here, the excess body weight and the association of overweight and obesity among adults doubled from 25% to 40%. And also in boys and girls, these results seem to be even more important, with an increase of about 5 times. But also the distribution of obesity varied from, in 1975, we have that was prevalent in high-income Western countries. However, in 2016, we have that, let's say, more equal distribution of obesity, and particularly with increase in prevalence of obesity in the East and Southeastern Asia. But why obesity? Obesity is important because it is a real risk factors for several diseases, not only for cancer, and particularly for cardiovascular diseases, for non-alcoholic fatty liver disease, for stroke, for hypertension, for pulmonary disease, for phlebitis, for pancreatitis, and so on. But when we talk about obesity, we should define how, let's say, we can define obesity. And often in the paper that I will present you in this presentation, obesity was measured as a body mass index. So why body mass index? Because BMI is strongly correlated with absolute adiposity measured by densitometry. That is at now the gold standard for measuring overall obesity. And it's reproducible and allows comparison within and across population. However, BMI is an indirect measure of obesity because it does not differentiate between fat and lean mass, and may underestimate the prevalence of visceral adiposity because it does not differentiate the site of adiposity, for example, visceral adiposities versus peripheral adiposity. And in some types of subjects, for example, in the elderly, is maybe a not accurate predictor of adiposity because, for example, the elderly had a loss of lean body mass because they experienced the sarcopenia. But it's the same also for highly muscular individuals of extreme height. And at the same time, and at the same BMI values, women, for example, had higher fat percentage, and conversely, men have higher lean mass. So we have also other measures of body fatness, for example, the waist circumference and the waist to hip ratio. And waist circumference and waist to hip to hip ratio are better indicators for cancer risk, particularly for cancer associated to visceral fat, so the colon cancer and postmenopausal breast cancer. However, also waist circumference and waist to hip ratio only approximate the visceral adiposity because they characterize not only visceral adipose tissue, but also the subcutaneous adipose tissue at waist level. But why BMI is important? This is a very interesting paper that analyzed more than 1 million people, and BMI, having a higher BMI correlated positively with the increasing mortality for all causes. And as we can see from these curves, this association was independent from the smoking, that is another important risk factor for the mortality. And also for higher BMI are associated with increasing incidence, particularly of some type of cancers, such as colorectal cancer, postmenopausal breast cancer, but also endometrial cancers. So these are the results of a really important study published in Lancet in 2009. However, recent papers tried to evaluate the population attributable fraction of cancer attributable to excess body weight. And now we can see in this slide, a fraction of all patients with a specific cancer can be attributable only to the risk factors excess body weight. This is particularly true for example, for esophageal adenocarcinoma, both in men and women, that in which the obesity is important to develop about 1/3 of all esophageal adenocarcinoma. And this is true also for the endometrium, so the endometrial cancer. And here we can see for the first time the term thyroid cancer, in which a small but not negligible percentage of cases are attributable to obesity, about 6% in men and 7% in women. If in this slide we can see how about half of all cancer attributable to excess body weight occurred in high-income Western countries, this is not so for the death for cancer attributable to excess body weight, because as we can see here, the mortality is higher in East Asia, particularly for breast in blue, for colon in red, and for esophageal cancer in green. And this is probably because the higher incidence of esophageal cancer in East Asia, and because esophageal cancer is a cancer very difficult to cure. So several papers demonstrated a correlation between or better, an association between obesity and cancer. But the question is, which are the mechanisms underlying this association? So several mechanisms should be implied in this causal relationship. For example, from the expanded and reprogrammed metabolic active adipose tissue to a direct effect of obesity on cancer cells, an indirect effect of tumor microenvironment, but also the changes in systemic physiology of patients or subjects with obesity. And so we have several mechanisms that can interplay and interconnect to characterize this association. And these mechanisms often work together and they, let's say, interconnect with each other to stimulate cancer development. So we can look at most relevant of these mechanisms. For example, the hyperinsulinemia. We know very well that in subject with obesity, we have an insulin resistance with an insulin with an hyperinsulinemia, and this is a relevant mechanism. But why is a relevant mechanism? Because in subject with obesity, we have a decrease in EGF binding protein and a consequent increase in EGF1 and EGF2, but particularly in EGF1. And moreover, we have the insulin resistance and so the hyperinsulinemia. So we have the activation of receptor of insulin, particularly insulin receptor A, but also of the EGF1 receptor that is overexpressed in cancer tissue. So this led to an activation in several pathways that cured, that managed thyroid cancer know very well, the PI3K AKT mTOR pathway and the MAP kinase pathway. And this is very important because these are pathways that stimulate proliferation and tumorigenesis. Another important mechanism is the hormonal imbalance that we observed in subjects with obesity. And this is particularly due to the peripheral adipose tissue. In fact, what happened in obesity? We have an increase of the, let's say, quantity of the aromatase in the peripheral adipose tissue, with an increased conversion of androgens in estrogens and an increase in estrogens, and in particular in estradiol. This is relevant because as is one of the mechanisms that increase cell proliferation and decrease DNA damage repair. And this is particularly true and particularly important for the onset of cancer in those cancers that are sensible to estrogen, for example, the breast cancer in postmenopausal women and the endocrine cancer. The endometrial cancer, sorry. And another important mechanism is the cytokines imbalance and the chronic low-grade inflammation. We know that usually we have two main adipokines, the adiponectin and the leptin. The adiponectin has a direct inhibitory effect on cancer cells. It is an anti-inflammatory and insulin sensitizing cytokine, while leptin is a pro-inflammatory, promotes T cell proliferation, and suppresses regulatory T cells. But what happened in subjects with obesity? In obesity, we have an increase of adipose tissue hypoxia with a chronic low-grade inflammation, and this led to an increase in inflammatory cytokines such as TNF-alpha, interleukin-6, interleukin-1, interleukin-10, and a concomitant increase in free fatty acid and reactive oxygen species production. And concomitantly, we have also a decrease in adiponectin level, and we know very well that in several cancers we have the hypoadiponectemia and an increase in leptin level. All these processes led to an increase in the neoplastic transformation of the cells. However, as I told you before, the mechanisms underlying the association between obesity and cancer are many, and that now not all are completely understood. For example, we have the direct or a direct effect of local ectopic fat tissue, the microenvironment and cellular perturbation, the altered intestinal microbiome that could be very relevant, the immune system imbalance, the genetic, the impact of quantity and quality of dietary nutrients, and so on. Another interesting question could be, but is there a thyroid-specific mechanism of linkage between obesity and thyroid cancer? Well, in subject with obesity, we have an increase of fat mass and fat-free mass with an increase in T4 disposal and a normal or decreased level of FT4. This led to an increase in serum TSH to increase the T4 secretion. So usually we also in a subject with obesity without thyroid dysfunction, we have an increased levels of serum TSH that isolated, the so-called isolated hyperthyroidopenia is frequent in the obese subject. And recently, our group published a paper that showed that in the thyroid gland of subjects with obesity, there was an increased number of adipocytes compared with overweight and obese. And this could be another mechanism to explain the increased TSH levels in subjects with obesity. And as you can see in the extreme right of the slide, these are histologic section of thyroid of subjects with obesity, and you can clearly see the infiltration of the adipocytes. But is the high TSH level a risk factor for the onset of thyroid cancer, particularly differentiated thyroid cancer? Yes, there are several papers that demonstrated that TSH as a risk factor as a carcinoma initiator, but also as a carcinoma propagator. And we, in a paper of, let's say, 10 years ago in PISA, we demonstrated that patients with PTC had higher TSH values if compared with benign thyroid diseases across all age. And when we in the graph on the right evaluated the rate of PTC, we know that the rate of PTC increases with increases of TSH level in a significant way if compared with patients with suppressed less than 0.4 levels of TSH. And interestingly, this mechanism was independent from the presence or the absence of thyroglobulin antibodies. Okay, but why thyroid cancer with obesity? Because thyroid cancer is increasing with the same trend over time if compared with obesity. As you can see in this slide from the SEER data, we can see how there was an increased incidence of thyroid cancer between 1992 and 2000, let's say 2010. Probably the publication of guidelines attenuated this increase in incidence. And if we look at the very recent data, showed that the thyroid cancer is the 7th cancer for number of estimated new cases in the United States. And fortunately, we do not have the thyroid cancer in the estimated deaths, nor in males and in females. Okay, this is a very interesting review of 2014 that showed as obesity and thyroid cancer, according to the data for obesity of the National Health and Nutrition Examination Survey and for the National Cancer Institute Surveillance and Epidemiology and Then Result Program, that obesity and thyroid cancer increased at the same way over time from 1960 to 2010. So the first question is, does obesity promote thyroid cancer? So to answer this question, we should go into detail of some key studies. The first I want to talk about is a very important study, is a European prospective study that takes into account the European prospective investigation into cancer and nutrition, the EPIC cohort that enrolled more than 500,000 people recruited from 1992 to 1998 in 10 European countries with a data lock between December 2007 and December 2009. Several patients were excluded, so those patients who had other cancers, those without available data about anthropometric variables, and several index of adiposity were evaluated. So they detected about 600 thyroid cancer cases, prevalently differentiated thyroid cancer, prevalently females and papillary thyroid carcinomas. And when they tried to find an association between anthropometric factors and increased incidence of prevalently papillary, because it's the most common tumor that they found, they showed as an increasing weight was positively associated with the increasing incidence of papillary thyroid cancer. And this was true also for the upper quintiles of high, and an increase of 5 centimeters, and a leg length greater than 77.5 centimeters. And these are the data in women. Okay, for BMI, if we look at BMI, we can see that not all categories of BMI, both if divided in quintiles or in WHO categories, had significantly association with increase in the incidence of thyroid cancer. However, if we looked at particularly in WHO categories, we can see a clear increasing trend, for example, from underweight patients to obese patients, also without statistically significant, but the trend is really positive. And the same things can be the same thing can be noted for the waist circumference, for the hip circumference, and for the waist to hip ratio. these are the results in men. So the results in men are less relevant than those in women. You can see that some category could be associated with an increase in the incidence of papillary thyroid cancer. For example, some of the tertiles of the eye and having a longer leg length. But the trend is not so, let's say, positive as we can see in the female population. And so no positive association were noted for BMI according to tertiles and 5 kilograms per square meter increase, for BMI according to WHO Caucasian categories, for the waist circumference, the hip circumference, and for the waist to hip ratio. So the authors in this prospective study concluded that a moderate increase in DTC risk, particularly papillary, is evident and is associated with increasing body size. And there was also a moderate positive association of differentiated thyroid carcinoma with overweight and obesity in women, but not in men. And this is probably due to the small cases of papillary thyroid cancer or differentiated thyroid cancer detected in men. However, in this study, we have a lack of systematic information about several risk factors, for example, radiation history or history of benign thyroid diseases. And we have a difference in diagnostic practice among the countries involved. We should remember that here we have 10 European countries, and all countries probably have a diagnostic practice to highlight the thyroid cancer different from another. So in this slide, several papers were published over the year up to 2015, and they were put together into a meta-analysis that tried to evaluate the association of overweight according to BMI and obesity according to BMI, and increasing the incidence of thyroid cancer. And we can see how the authors concluded that a positive association was found between overweight and thyroid cancer incidence, both in men and women, and the same thing is also for the obesity. So subject with obesity has an increased risk of having thyroid cancer over time. But I want to stress this very, very interesting study. This is an American study that analyzed the 22 prospective cohort studies from North America, Europe, Australia, and Asia, and several measures of adiposity were evaluated: height, baseline BMI, the young adult BMI, the adulthood BMI gain, waist circumference, and they correlated these anthropometric factors with the risk of having thyroid cancer. In this study, not all body measures were assessed in all studies reported, and sometimes the anthropometric factors were self-reported. However, after the exclusion of patients without follow-up time, with a previous diagnosis of cancer, and so on, we have a final cohort of more than 2 million people, followed for an average time of 10.4 years. And they found about 3,000 thyroid cancer cases, prevalently differentiated thyroid cancer, and prevalently, again, females and papillary thyroid cancer patients. But I want to stress that in this paper, the author, and this is, in my opinion, one of the real strengths of this study, these data were adjusted for several confounding factors. For example, the age, for example, the marital status, but also, for example, the smoking. And in this table, I want to underline that higher high was associated, positively associated with thyroid cancer in women and in the total population. Higher baseline BMI was positively associated, but only for 5 kilograms per square meters. Also, having a larger waist circumference was associated with the risk of having thyroid cancer only for some categories. But the very interesting data, in my opinion, in this paper was that the young to adult BMI, so having a higher BMI, higher than 25 young adult BMIs, is correlated to an increasing risk of having thyroid cancer during the life. And this is true also for the continuous variable, so per 5 kilograms per square meter. And it's the same also for adulthood BMI, because we have that in cases of adulthood BMI gain between 5 and 9.9 kilograms per square meter, we have a positive association with increasing the incidence of thyroid cancer. However, when we dividing the patients according to histotype, so papillary, follicular, medullary, and anaplastic thyroid cancer, we noted as a higher high was associated with an increased risk of having papillary thyroid cancer, such as an higher young adult BMI. Higher high and higher baseline BMI were associated with increased risk of having follicular thyroid carcinoma, but probably the most interesting data regarding the medullary and anaplastic, because we see that in medullary thyroid cancer, the others failed to find any significant association. And conversely, in anaplastic thyroid cancer, a baseline BMI in a higher baseline BMI in women and a higher baseline BMI in the total population and the high adulthood BMI gain in the total population had a real important, strong association, strong risk to be associated with increase in the incidence of thyroid cancer. But I think that this is the first study that evaluated the mortality, the thyroid cancer mortality associated with anthropometric factors. And it's a higher and a higher baseline and young adult BMI and larger waist circumference. Also, the cases are probably, there are few cases, were positively associated with thyroid cancer mortality. So the authors concluded that more or less all anthropometric factors evaluated were positively associated with increased risk of having thyroid cancer. But only some of these factors were statistically significant, showed a statistically significant association with increased risk of thyroid cancer. But these associations were independent of smoking and other risk factors. And the risk pattern was similar for papillary thyroid carcinoma, for follicular thyroid carcinoma, anaplastic thyroid carcinoma, but not for medullary. And there was a strong association between baseline BMI or BMI gain and anaplastic thyroid cancer or young adult BMI and thyroid cancer mortality. But this data about, let's say, the having a higher BMI in younger age was very well reported in a previous paper in 2014 and analyzing more than 300,000 children aged from 7 to 13 in a large Danish registry linkage study. And the author clearly demonstrated that having a higher BMI in young age was correlated with an increased incidence of having a thyroid cancer in adult age. But for what histotype? Again, for papillary thyroid carcinoma. So they concluded that these results, together with the relatively young ages at which thyroid cancers are diagnosed, compared with other malignancies, suggest a potential link between early life factors related to growth and body weight and thyroid carcinogenesis, particularly for papillary thyroid carcinoma. So according to these very convincing data, in 2016, the International Agency for Research on Cancer, IARC work group, included thyroid cancer into the cancers in which obesity was a proven risk factor, the so-called obesity-related cancers. This evidence is so strong that is confirmed in a recent pooled analysis involving more than 24 million people. And as you can see, being overweight or obese led to an increased risk of having thyroid cancer in a significant way, both in overweight, but particularly in obese. But I want to stress the concept that to be underweight, as you can see here in the upper part of the slide on the left, to be underweight is a protective factor for the development of thyroid cancer. Okay, we mainly discussed about European and American population, but what happens in Asian population? This is a very recent paper published on thyroid some months ago, and we can say that these are the data for women, and these are the data for males, and were analyzed with more than 500,000 people, and we can conclude that in Asian population, we can find, the author found a positive association between higher BMI and increased risk of having thyroid cancer. However, this association is not so strong, and particularly this data is real in women. Okay, so the evidence showed that obesity could be considered a real and recognized risk factor for thyroid cancer incidence. But does obesity also increase aggressiveness of thyroid cancer? In this very interesting study, Kari Kitahara and co-authors used an innovative approach that, let's say, combined relative risk estimates with annual data from national health surveys and cancer registries to estimate the impact of overweight and obesity on USA trend in PTC incident rates overall and stratified by age and tumor size. They analyzed about 500,000 people, and they evaluated only the middle to older age adults, so the population between 50 and 71 years, all cancer-free at baseline. They detected about 600 thyroid cancer cases, papillary thyroid cancer cases. And the result clearly showed that being overweight and obese led to an increased risk of having larger tumor size, so larger papillary thyroid carcinoma, larger than 4 centimeters. So since several papers were published on this issue, and differently from the previous regarding excess body weight and the incidence of thyroid cancer, results are more controversial. Two recent meta-analyses assessing more than 60,000 people tried to put together these studies and evaluate the impact of obesity on aggressive features of thyroid cancer, particularly PTC. As you can see here, the evaluation between the evaluation about tumor size. So the subject with obesity had a higher risk of having a larger tumor size, both measured in continuous variables, such as in this review, and as a categorical variable in this other review. And the evidence are consisted also for multifocality in both the studies, for extrathyroidal extension, and also for lymph node metastasis. I want to show you, however, that several of these studies have let's say, very wide confidence interval. So the data are not so clear, such as the data about obesity and the incidence of thyroid cancer. Indeed, there are open issues about the association of obesity with aggressiveness of thyroid cancer. And for example, the histology definition of thyroid cancer, because considerably changed over time. So the analysis of aggressive features, particularly if these studies are not so recent, could be a bias. And often in this paper, we have a lack of systematic information about histologic variants of papillary thyroid carcinoma, of number, dimension of metastatic lymph nodes, and absence of information about vascular invasion. And several papers were performed, were evaluated Asian people. So Asian and Caucasian are very different, have different body composition. So different BMI categories in different ethnicities could be another bias. And few studies included information about duration of obesity, weight history, smoking, alcohol intake, genetic and environmental factors, the role of hormones and cytokines, and patient's medical history. And only some study explored an important association, because if we say that in obese cancers are more aggressive, however, this is not reflected with an increase in recurrence rate and increase in mortality rate. So this is another important point to evaluate. Probably having a PTC, those patients who have a PTC had an infrequent occurrence of this event. Okay, on this regard, I want to show you some study that was not reported in the meta-analysis that I showed you before. And this is probably one of the first study. This is an American study who analyzed 259 consecutive differentiated thyroid cancer patients followed up for a mean time of 6.2 years. And the authors failed to demonstrate any positive association with BMI with an increase of 10-point increase in BMI with aggressive features, such as tumor invasion, vascular invasion, distant metastasis, tumor sites, nodal metastasis, and the persistence of the disease. And if we looked at this European study in 2018, who analyzed 432 differentiated thyroid cancer patients, in which obesity accounted for about 20% of the whole study population, they failed to confirm any statistically significant association between aggressive features of thyroid cancer and obesity. Also, our group performed a study about this issue. We analyzed about 1,000 differentiated thyroid cancer patients, prevalently PTC. Obesity accounted for about 20% of the cases, and all our patients were or surgical treated in Pisa, or histology was derived from our pathologist in Pisa. BMI was measured at the same time for all patients. So at the time of first radioiodine treatment, all these patients performed the radioiodine treatment about 3-4 months after surgery. And the clinical, biochemical, and imaging follow-up were taken at the same institution over the follow-up time. So we failed to demonstrate any statistically significant association between larger tumor size and aggressive histology. We evaluated also the papillary thyroid carcinoma variant, the PT stage according to TNM 8 edition, the multifocality and the bilaterality, the presence of minimal extraterritorial extension, the surgical treatment on lymph node that was performed, so central compartment only, or central compartment and lateral cervical compartment, the end stage, the staging according to 8 edition, and also the risk of recurrence according to ATA guidelines, the radioiodine activity administered, and how was the method to increase TSH, so LT4 withdrawal or recombinant T1 TSH, and the results of post-therapeutic whole body scan. So none of these features was correlated in a statistically significant way with overweight or obesity. And also when we followed up these patients during the time and we evaluated the number of surgical reintervention for persistence of recurrence, the number of radioiodine treatment performed over time, and particularly the response at last evaluation in a follow-up of about 6 years, according to ATA guidelines, so we cannot find any statistically significant association with overweight and obesity. But since in higher population, higher BMI was significantly associated with male sex and older age, therefore we performed a new analysis of the clinical characteristics before and after correction for sex and age, analyzing BMI as a continuous variable. But again, we have no association with aggressiveness of thyroid cancer. However, when we looked at the risk factor for cancer, obesity was a modifiable risk factor for cancer. We have the unmodifiable risk factors, modifiable risk factors, and treatable risk factors. So what's happened in the also in the media, that there is a several suggestions about the lifestyle intervention. I take one of the web pages, the page of Center for Disease Control and Prevention, and also if, and this is important to remember, the association between weight loss and subsequent cancer risk has not yet been established, and as well as the association of excess body weight with cancer survival. Several measures were available to evaluate the obesity and to treat the obesity. For example, the screen for obesity also in children, lifestyle intervention, reducing the unhealthy diet and reducing the physical inactivity, the use of new and old obesity drug, and the use of bariatric surgery in morbid obesity. So I can conclude that increased BMI is associated with raised incidence of thyroid cancer, particularly papillary thyroid cancer, but also follicular and anaplastic thyroid cancer, but not medullary thyroid carcinoma. That several pathogenetic mechanisms interconnect to explain the link between obesity and thyroid cancer. And obesity does not play a clear role in worsening the aggressiveness of PTC. So patients with obesity should be considered for neck ultrasound, particularly if we, during the clinical visit, have some difficulty to palpate the neck of the subject. However, currently, no tailored management is suggested in case of diagnosis of thyroid cancer in subject with obesity. So once diagnosed, the thyroid cancer, but particularly PTC, should be managed following the conventional workup as in normal weight patients, based on the clinical presentation of the disease and including active surveillance, if appropriate, as recommended by referral guidelines. And my last slide is about the future direction. So we know that obesity could be associated with dysbiosis, and this led to an imbalance in microbiota, favoring inflammation, altered metabolism, and genotoxicity. So probably in the future, it's very important to understand the microbiome. And very important is also to say that obesity alters the tumor microenvironment, which can play a role in worsening the cancer, so in cancer progression. And we need offshore or prospective studies with complete information about the measures of adiposity. So BMI, waist circumference, and other measures of adiposity. The NCI consortium combines more than 50 prospective studies. But why the prospective studies are important? Because a large number of patients are important to give us information about, let's say, less common cancers, such as thyroid cancer. And lastly, the interventional studies, with intervention to prevent weight gain, but particularly the weight regain after weight loss. There are two relevant NIH initiatives about, and these studies are designed with the aim to identify the predictors of successful weight loss and maintenance, and to incorporate this information with other environmental and genetic factors. This is important to define the more effective weight loss intervention. But why is important to maintain the weight loss? Because maintaining weight loss in long-term follow-up study could probably give us the right answer to the question if weight loss is a key point in the prevention of cancer. And I want to thank you, all of you, for your attention.
Dr. Matrone, I want to thank you for a very insightful and very comprehensive appraisal of the literature and presenting your data to us. I think many of us have an incredible number of questions, and I'm gonna start them off as they come in through our Q&A. So you spoke about the association of obesity with the prevalence and the aggressiveness of thyroid cancer. But tell us a little bit about, do you think these same concepts apply for example, normal weight obesity or sarcopenic obesity?
Okay, so this is a very interesting question. So it is clear that obesity is we have several types of obesity. Okay, so we have that it is important to have an healthy obese or an unhealthy obese. If we have healthy obese, so I think that in this case we have no problem to say that that cannot be any association with aggressiveness or increased incidence of thyroid cancer. However, when we have an unhealthy obese and our opinion could change because we have that, for example, several mechanisms in an unhealthy obesity are important to to develop to favor the thyroid cancer incidence, for example, in the hyperinsulinemia. So when we have the sarcopenia, for example, in the elderly, and it depends if we have a healthy obese or unhealthy obese. If we have an healthy obese, we have no problem.
That sounds interesting, and you bring hyperinsulinemia to the mix, and it's a very interesting topic, and we could speak for hours about hyperinsulinemia. But tell me, do you think there is room for observing clinical features such as acanthosis nigricans? I don't know, you know.
Yes, yes, the clinic is very important. These are all signs of hyperinsulinemia or insulin resistance, and this could be very important when we evaluate an obese subject, because when we evaluate an obese subject, okay, we take the weight, okay, we take the height, okay, but all these signs could be important to define the obese status. For example, the acanthosis nigricans is associated with hyperinsulinemia, so with let's say an unhealthy obesity. And this is important also when we decide, if we decide to check the neck of these patients, because let's say the neck of the subject with obesity is not so simple to palpate, and so it could be an option to perform neck ultrasonography if we have several signs, clinical signs of an unhealthy obesity, because we know that, and I showed you the data before, that we have an increasing incidence of thyroid cancer in obese people. So it could be an option. It is not mandatory, but it could be an option to evaluate the clinical status of the subject at time of clinical visit.
Exactly. So I was going for these clinical signs, skin tags, acanthosis nigricans, or maybe some biomarker of hyperinsulinemia that would drive us to be more aggressive in the screening, in the follow-up of patients with thyroid nodules. So, you know, in other diseases in endocrinology, for example, in gestational diabetes or different topics, we do have like panels, or we do have uh, types of phenotypes of patients that we tend to screen faster or screen earlier in life to prevent complications from hyperinsulinemia or such. So do you think that there is room for creation of a phenotype of a type of patient that I don't know? You were mentioning in your study high TSH is a good factor for thyroid cancer development. You mentioned the aromatase scenario where you have more estrogens. You mentioned a couple of factors. So being a woman, having high TSH, being young, is there a room for a phenotype that we can construct to start potentially in those type of patients screening and surveillance earlier in life rather than finding them after you have a palpable mass, for example?
Yes, Camilo, this is a very acute observation, because we have, I think that when we talk about thyroid cancer, we have several risk factors that we should take into consideration, independently from obesity. For example, the presence of an history of radiation, the familiarity for a familial history of thyroid cancer. But also, if we when we have a particular phenotype, and we should be careful to evaluate this patient, because it is not probably, but there is an increased risk of having thyroid cancer. I don't know if it is the time to have a, let's say, a personalized medicine for these patients, but it could be an interesting idea.
I'm sorry, I didn't mute myself. Do you know of any biomarkers? For example, there's a very, I think, too liberal use of surrogate markers of hyperinsulinemia, like say the HOMA index, the euglycemic clamp, or such. Do you think those have a room for helping us evaluate which patients are in risk based on their obesity, of course, to develop thyroid cancer?
Okay, I think that when we talk about the association of obesity with thyroid cancer, we should remember that the relative risk is the association is positive, but is not so positive. For example, as for breast cancer in postmenopausal women or for endometrial cancer. So all this, those who can help us to identify the subject at the higher risk of having thyroid cancer is useful. But let's say, I don't know if we have precise biomarkers. We have a series of information, clinical, biochemical, and prevalent clinical and biochemical, that help us in identifying those patients at higher risk of having cancer, because this is of having cancer. So thyroid cancer is more, let's say, complicated.
Okay, that's very, very interesting. And I wanted to ask you, and going back to the data that you presented in one of the studies, you presented the hyperthyroidtropinemia. Yeah, as part of a risk factor, and then you presented your data based on the presence of thyroglobulin antibodies. Why thyroglobulin antibodies and not, for example, peroxidase antibodies?
Okay, this is a very important question. So we know that the peroxidase antibodies are the let's say real marker of thyroiditis. But conversely, in the first time, in the first month, in the first years of thyroiditis, we can have a positivization of thyroglobulin antibodies more than thyroperoxide antibodies. And often when we have the positivity of thyroperoxidase antibodies, we have also the positivities of thyroglobulin antibodies. So we decided to use thyroglobulin antibodies because it's a marker of, let's say, early thyroiditis, but also associated with thyroperoxidase of thyroiditis of old data thyroiditis. However, the message is very important, because the microenvironment in the thyroiditis could favor the onset of thyroid cancer, because there is inflammation and so on. However, probably it is not the thyroiditis that guide the onset of thyroid cancer, but probably it's the high TSH levels in these patients.
Very, very interesting. I wanted to ask you a question that is a little bit off topic from what we're speaking right now, and
okay.
there's a couple of listeners or people listening right now that are rock stars in the field, and you were mentioning in your study, you gave us an image of thyroid tissue after surgery that had a lot of adiposity, and I'm sure Dr. Brandwein is on the call is curious to know how you found that, and how you describe that, and how important the adiposity that you found in these patients was.
Okay, so they have, as you can see here, the division of patients was according to BMI. So we have normal weight, overweight, and obese, and we have several grades of obesity. So higher than 30 milligram per square kilogram per square meter. So we have greater several different obesity in our study. However, higher is the obesity, and more frequent is the finding of having adipocytes into the follicular cells. So it is clear that if you had higher obesity, you have more probabilities to have the adipocytes in the follicular cells.
Awesome, and very interesting.
between the follicular cells, among the follicular cells.
So between, like within the follicular tissue.
Within the follicular, sorry, within.
Very interesting. Dr. Elise is asking us, should obese subjects with thyroid cancer be treated with a more aggressive surgery?
Okay, this is a very another very interesting topic. So I told you before that if we find thyroid cancer, we should not treat those patients with a more aggressive surgery. But there is a reason to this assumption, because if we look at the data of the complication of thyroid surgery in obese patients, not me, but my surgeons tell me that the postoperative complication, for example, the bleeding, the recurrent laryngeal nerve injury, and the permanent hypopara, are not more frequent in obese than in normal weight subjects. So you can treat the obese, the subject with obesity with thyroid cancer according to that we found at neck ultrasound, at the CT scan, as a normal patient. So they do not need an aggressive surgery only because they have obesity.
Okay, this is a very interesting question, because I think all through the journey of a thyroid cancer patient, there is room for change in their treatment, and I agree the data supports having the regular journey for a patient with obesity. But if you go to surgery, there could be a question about changing the activity of radioactive iodine dosage for patients with a higher BMI. There could be a question of is it more common to find cancer in those thyroid nodules that are biopsied in those patients that are actually obese? So there's many parts of thyroid cancer that could be impacted by the
Yes,
BMI.
this is a very interesting field. I can tell you that in our experience, for example, we did not take into account obesity when we performed radioiodine treatment, for example, because we used a fixed dose of radioiodine. And from the data that I showed you before of our study published on JCM, we have no difference in the outcome of patients treated with the same radioiodine activity between overweight and obesity. Slight difference is the question about thyroid nodules, because there are, I think, two important studies, one from Italy, published by Mario Rotondi in Pavia, that evaluated more than 5,000 patients with thyroid nodules and divided the patients according to overweight, obesity, and normal weight patients. And this study, the authors found no difference in the prevalence of suspicious of malignant nodules according to BMI. But the same results were recently reported by an American group, if I remember, of Boston and Los Angeles, I believe, that also they demonstrated that they did not find any association between BMI and the risk of having a suspicious or malignant cytology, clearly, for papillary thyroid carcinoma in thyroid nodules. So probably this study are interesting. The data are really good, but they suffer for missing data about the real prevalence of thyroid nodules in patients according to the different classes of BMI. So they cannot provide an estimation of the real incidence of thyroid cancer subject in the thyroid cancer in subject with the overweight or obesity. But the study are very well designed and important studies.
It would be really interesting to see similar data coming from the people in Asia and Korea and Japan with lower incidence of obesity, with different screening methods, because they do a lot more ultrasound than we do in this side of the world. So the difference in data would be really amazing to compare to see if there's...
Indeed, they have a higher incidence of thyroid cancer because they use a lot of time neck ultrasonography.
Exactly, and a very much lower incidence of obesity. So very contrasting data that could come out of those two different studies. So we're about to hit the the 9 o'clock hour here. I want to thank you on behalf of everyone for your incredible presentation. We wish to have all of you back next week with our next Virtual Journal Club. We'll have Dr. Sid Finkelstein speaking about the role of epigenomic and microRNA in growth control, diagnosing versus malignant determining phenotypic expression of thyroid nodules, and following a couple of tumor boards that will be especially in pediatric tumor board and adult tumor board following that. So thank you, Dr. Matrone, for your insightful presentation.
Thank you very much.